Hi, my name is Courtney Rosenthal, and this is my Module 1 discussion. In this post, I'll be discussing the impacts of pharmacokinetics, pharmacodynamics, and pharmacogenetics in my professional practice. I'll try to use examples from my work to illustrate these concepts in action. Pharmacokinetics are hugely important in the ICU. I work in a surgical trauma ICU at a level 1 trauma center, in which most patients are suffering from multi-organ system failure. For example, many of our patients are on vasoactive medications, such as Levophed or norepinephrine. We know from research that norepinephrine can impair renal and gastric blood flow. This greatly impacts the types of medications used, as well as the dosages of these medications. In our situations, we're forced to weigh the benefits of these medications, such as continued brain and heart perfusion, with potential side effects such as renal failure. In our textbook, Oral Medications, we learned that oral medications are absorbed through the cell lining of the GI tract. In a patient on Levophed, both the blood flow and gastric motility are decreased, leading to a decreased absorption of PO medications. Once Levophed is discontinued and blood flow returns to normal levels in the GI tract, any residual medications in the GI tract may have increased absorption. This is why in many ICUs, oral medications as well as enteral nutrition are used cautiously. We have a team of pharmacists 24 hours a day to help monitor and make suggestions about route and dosages of medications. Pharmacodynamics are also important in my field. The potency of each drug given to my patient is based on the efficacy as demonstrated by patient response. For example, while providers may first prescribe first-line antimicrobials for sepsis patients, they may see a less than optimal result from their patient. This may require adjusting the dose or potency of the medication or choosing a different drug to improve efficacy. Also, while many of these antimicrobials can increase gastric motility and induce diarrhea, this would greatly decrease the absorption of other medications, leading to a possible increased dosage of medications needed. Pharmacodynamics also impacts our choice of medications. To illustrate this, I'll return to vasopressors. Norepinephrine is a dramatic agonist for both alpha and beta receptor sites. Other vasopressors, such as neosynephrine or dopamine, may be more appropriate choices given the patient's pathology. Each of these drugs works more selectively on receptor sites. That being said, these medications are no less dangerous. For example, a spinal cord patient may be a fantastic candidate for dopamine infusions, since dopamine works on beta receptor sites and can increase heart rate for these notoriously symptomatic bradycardic patients. However, the same beta adrenergic effect could be lethal in a patient experiencing tachycardia. As our book mentions, the specificity researchers provided in studying alpha-1, alpha-2, beta-1, and beta-2 quote, permitted more specific drug therapy, unquote. These drugs have a relatively low margin of safety, which is one of the reasons these drugs are only permitted in the closely monitored ICU environment. Rarely are pharmacogenetics considered in my line of work. The exceptions include our oncology patients, particularly those receiving a type of therapy called IL-2 therapy. For example, certain patients may suffer from autoimmune disorders that disqualify them from IL-2 therapy. In the future, it would be wonderful if providers were able to implement pharmacogenetics in a time-sensitive way that's required of most acute traumas. Overall, I'm looking forward to understanding more deeply the pathophysiology behind the medications I deliver. I think this will make me a better patient advocate as well as a safer nurse. Thank you.